Good morning, everyone. I'm Dr. Tara Kiran. I'm a family doctor at St. Michael's Hospital and the Vice Chair for Quality Innovation at the Department of Family and Community Medicine at the University of Toronto. I'm delighted that our department can continue to bring you these sessions together with the Ontario College of Family Physicians, and I'm going to turn it over to their president right now, Mekalai Kumanan, who will be introducing the session. Mekalai?
Thank you, Tara. Good morning, everyone. I'm so happy to be here with all of you. This is our last session for the year, and we've got a great one lined up for you. I'd like to just take a moment to thank our panelists and to remind you that this is a Maine Pro accredited session with details following via email. Next slide, please. So I'd like to just move on to our land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories we are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And today I'm calling in from Kitchener, the lands traditionally used by the Haudenosaunee, the Anishinaabe, and the Neutral people. Next slide.
Following the land acknowledgement, we've often reflected on continued injustices perpetrated towards Indigenous people and the continued effects of colonization. And today I wanted to not just reflect, but also move forward to thinking about action. And I'm delighted that our new strategic plan for the Department of Family and Community Medicine has a number of commitments in there that really help to move us towards decolonization and addressing the injustices that we know exist. And this includes us trying to do better when it comes to addressing having every person who is Indigenous within our community attached to primary care, because we all know how important that is. And doing that in a way that works for them, that's designed by them. So I'm so delighted that our department has these actions within our strategic plan. Next slide. Our sessions, as you know, build on one another. We had a great session last time as well, and you'd be able to take a look at the recordings from our last session where we started to talk, for example, about virtual care, and you can get that from the link, and the recording from this session, as well as the slides and the resources will be posted there as well. And a shout out to our hardworking planning committee who helps to make these sessions happen. Next slide. So delighted to introduce our panelists in a moment. Next slide. And of course, very happy to be co-hosting this with our wonderful co-hosts. So I'm going to first turn it to Kevin to introduce himself and to speak to his disclosures.
Hi, thanks very much. I'm a family doc in Rockwood. I've been doing virtual care since well before the pandemic, and it's going really well. And I'm looking forward to sharing some insights with you today. Conflict of interest, I have received funding for work that I've done as an advisor and presenter for the organizations shown. I'm a board member of AFDO and have also acted as a clinical advisor for Ontario Health. I have no biases to declare for this presentation. Thank you.
Zain?
Hi, everyone. I'm Zain Chagla. I'm an associate professor at McMaster, infectious disease physician. My conflicts of interest are mainly through education with a number of companies in COVID therapeutics and a couple of research studies that have been sponsored by industry to help with figuring out whether or not drugs are appropriate, and the Gilead study looking at radiologic findings of people post-COVID, as well as OCFP for today.
Thanks. Danielle?
Morning, everyone. My name is Danielle Martin. I'm a family doc in Toronto, and I'm the chair of the Department of Family and Community Medicine at U of T. I'm a salaried employee of the University of Toronto. I bill OHIP for my patient care, and I don't accept honoraria. Thank you.
Mekalai?
Hi, everyone. I'm a family doc in Cambridge. I sit on the ECHO Chronic Pain and Rheumatology Advisory Board, and I do receive a stipend for my role as president, neither of which pose a conflict for today.
Liz?
Good morning, Liz Mugga, family doctor in Ottawa, and I'm an employee of Ontario Health as the senior clinical advisor in primary care, and I receive a salary from them for this role.
Thanks. Ali?
Good morning, everyone. My name's Ali Damji, and I'm a family physician from Credit Valley Family Health Team, and I'm also the division head of primary care for Trillium Health Partners in Mississauga, and I'll be a co-moderator for today, and no conflicts to disclose.
And I'm Tara Kieran, and I've listed some organizations who've provided either grants or salary support, as well as speakers honoraria, but none of them pose a conflict for today. Next slide. Today, we're going to be continuing a conversation we started last time on virtual care. There was lots of interest in it, and we're delighted that Kevin is here to help us with that. I'm going to introduce a new tool called Care Canvas and briefly walk you through it because we think it's something that might be able to help your practice. We're then going to go to our infectious disease update with Zain Chagla, and we are going to talk about new evidence related to boosters, as well as new criteria, new guidance that's come out around Paxlovid and Evusheld. And then we're going to end with Dr. Danielle Martin talking about some of her and the science table's reflections on the role of primary care during the pandemic. This is our 54th session since we started in April 2020. So it continues to be a milestone, and we thank you for those of you who continue to join us. This has been such a wonderful community. And it also means that it's time for, I've been moderating these sessions now for that time period, and it's time to bring someone else on to share that with me. And I'm delighted that Dr. Ali Damji is going to be doing that. So Dr. Ali Damji, as he mentioned, is a family doctor based at Trillium, and he's going to be moderating the rest of the session today. And so I'm going to turn it over to him.
Thanks so much, Tara, and really big shoes to fill. And I'm so grateful for your mentorship and also your leadership of this group. And really excited to be taking us through this today alongside with you. So just a reminder for everyone, and I just actually put it in the chat as well, is please remember to ask your questions using the Q&A function. It allows me as the moderator to better see your questions and make sure we can pose them to the speaker. And then also make sure to use the thumbs up button to upvote other guests' questions and use the chat box for networking and sharing your own experiences. Next slide, please. All right, and we'll go to the next slide to start with Dr. Samson.
Excellent. Thank you very much. Looking forward to this. It's actually my first 7-minute talk on virtual care, which is an interesting challenge, but here goes. I'm going to go over billing rules and tips, appropriate use, why virtual care, and tips on providing virtual care. Next slide, please. So there's been a fair bit of misunderstanding about the new billings, and I'm going to go over the basics and then some tips. Keep in mind that the details are specified in the updated schedule of benefits, and you can call the Claim Services Physicians Hotline at the Ministry of Health. The new claims for virtual care are basically divided into two main categories: comprehensive care and limited care. For comprehensive care, you need to have seen the patient in person in the past 24 months, or you need to be in an ongoing relationship with the patient. For docs in a patient enrollment model, this means that the patient is enrolled in the practice. So in other words, if a patient has signed an enrollment form, then you or anyone in your group or locums from your group can bill for the comprehensive virtual care, whether the patient's been seen in person in the last 24 months or not. For comprehensive virtual care, you get paid the same for video as you do for in person, and you get 85% for phone. You get 95% though for phone for certain codes, KO5, primary mental health care, and KO7, psychotherapy. When billing for comprehensive virtual care, you submit the same codes as you would for an in-person care and just add the modality indicators, which is K300 for video and K301 for phone. If the virtual care doesn't qualify for comprehensive care, then you can only bill for limited care. So $20 for video and $15 for phone. Next slide, please. And this is a busy slide, sorry about that, but keep in mind that the slides and references will be available after the presentation. So here's some key points about the Billings. Virtual visits can be initiated by patients or physicians. You must document the modality. The visits must be for medical reasons. You need to do the visit yourself. For comprehensive visits, follow-up in-person visits must be available if necessary. The patient and the physician must both be in Ontario at the time of the visit. Now, this is different from the CPSO and CMA, which allow you to provide virtual care in other circumstances, but these are the billing rules, both in Ontario at the time. In-basket rules are similar. Most of the premiums and management fees still apply. Virtual care claims are generally not applicable to inpatient care. For video, you need to use a solution that's been verified by Ontario Health, and the virtual visit must be clinically appropriate. Next slide, please. Which brings us to the topic of what's appropriate. There's two excellent documents that have recently been released about this. Healthcare Excellence Canada released their Clinician Change Virtual Care Toolkit in May. And last month, Ontario Health released their guidance document on the clinically appropriate use of virtual care. They both have helpful, practical tips for delivering safe, effective, and appropriate virtual care. Both documents highlight important decision points. Patient preference should be paramount. Patients' access to devices and data and their ability to use them needs to be considered. And clinicians need to assess what's available to them, when it's clinically appropriate, and what their competency levels are for the various types of virtual care. There's lots of examples of what's more likely to be clinically appropriate for virtual care. So rashes, follow-ups, counseling, discussing new results like high cholesterol, starting birth control pills, requesting referrals for vasectomies. There's lots of problems like these that can often be addressed without the need for an in-person appointment. Next slide, please. So why virtual care? During the height of the pandemic, this was really obvious, but why now? Part of the answer is that we should be focusing on equitable, patient-centered care. Virtual care is not for everyone, and it's certainly not for all situations, but it can provide access to care for patients who may not otherwise be able to get the care that they need. Attending an in-person appointment can be difficult for some patients. Transportation, cost, and time can be limiting factors. Some patients already struggle with the mobility or even just visiting the office due to anxiety. They could be much more comfortable with a virtual care visit from home. Virtual care can also allow family or caregivers to join the visit by adding them to the call or sending them a link to a video. And virtual care can be much more convenient, which can really actually make the difference between whether patients book an appointment or not. Next slide, please. Great. And there's the question of phone versus video. Clearly, more docs are offering phone than video. From a patient point of view, phone can be preferable. People can be more comfortable on the phone and they might not have access to video. Patients can be worried that video won't work or that won't be able to do it. And often patients don't really know about the benefits of video. Patients who've had a good video visit can appreciate that it can be more personal and better to see expressions and body language. They realize that with video, they can show the doc stuff like rashes, where the problem is, or what they can or can't do. And lots of people and patients are used to video now. They've been connecting with family and friends or having work meetings. So some of my elderly patients are pretty comfortable with their iPads because they've been using them during the pandemic to chat with their grandkids. Next slide, please. So how do we make this work? A lot of us struggled with systems that didn't work well, weren't a good fit, and we didn't really learn how to use them well. Systems have improved though, and the right approach can make a big difference. Go through the guidance documents. Choose a system that's going to work for you and your practice. I'm using a soft phone system, and it allows me to call patients from my cell phone, but displays my caller ID is coming from the office. So now my patients pick up. Choosing the right video system is critical. It really helps if it's integrated and doesn't require apps or setup, and there are systems like that now. Using a second monitor or yourself for video so that you've got good access to the chart during the visit makes a big difference. Brush up on your clinical skills for virtual care. We certainly didn't learn about that in medical school. Check with colleagues who are doing the virtual visits. Practice, and I can't emphasize this enough, be the patient, be the doctor, try different devices, practice. Establish good workflows and scheduling strategies. Build a list of visits that you're comfortable doing virtually. Help patients understand what works well with virtual and what's better in person. Our online booking system actually doesn't allow patients to book for virtual when it's not appropriate. Well, baby visits, PAP tests, that kind of thing. Doing a soft launch can also really help when getting started. In my clinic, we started with one doc and then gradually expanded to the whole clinic. Get feedback from your patients. Our system allows us to send an automatic post-visit survey so we can find out how it's working for them. And connecting with Ontario MD can really help. They can help with all of this, and it's a free service. Next slide, please. Virtual care, phone and video can work well for you and your patients and your staff. In addition to providing personal care, we should be offering virtual visits to our patients who prefer virtual or who have difficulty attending an in-person appointment. I enjoy virtual care, and so do a lot of my patients. And done well, it's really not more work. Virtual care can be a positive experience for everyone involved, even the PATs. We'll go to the next slide now. Just a list of resources that I've discussed during the visit, during the presentation. The last one there is just the soft phone system that I referred to. Next slide. And that's it. Thank you very much. I'm happy to entertain some questions, and I'll keep an eye on the Q&A as well.
Thank you so much, Dr. Samson. And as you can see, there's lots of great feedback for you in the chat there. So I'm next going to ask a few questions. And one of the questions actually came from the chat, and I think it's an important way to maybe start things with regards to virtual care. And that's regarding, that balance between clinical appropriateness and patient safety. And, should that be trumping patient preference? And just wondering if you could comment on that a little bit.
Yeah, I mean, with those decision points, they're all important. And going, what I showed on that slide, all of those conditions really need to be met for the visit to be appropriate. So first of all, if the patient doesn't prefer virtual, don't do virtual. But if the patient does prefer or is okay with that choice, then yes, it does depend on what our clinical judgment is in terms of whether it's appropriate. So really, it is that all those conditions need to be met in order for the virtual visit to be appropriate. And keep in mind that it's not necessarily binary. There are times where during a virtual visit, we'll realize, you know what, this isn't really appropriate as virtual, and we do need to bring you into the office, and that's okay. It doesn't have to be one or the other, and it can even be the other way around also. So it does boil down to a combination of factors, and clinical judgment and patient preference are certainly part of that.
Thanks so much. So why don't we go to one of the Q&A questions here, which is, what would you recommend to handle fee-for-service patients who haven't been seen in person in the last 24 months that demand a virtual appointment, but the doctor doesn't want to provide that for, the limited virtual care codes?
Yeah, it's definitely a great question, and it is controversial. There is, the problem is that if it's not comprehensive care, if it's limited, the billings are minimal. $15 and $20 is not really sustainable for a lot of physicians. So although the idea is there's some good to the idea that we should be promoting comprehensive care, there are, first of all, patients who don't have access to a family doctor, and there are doctors who are providing them a good service virtually that may not be able to continue to do that. And then there's more towards this question, which is, what if you have a patient? If you're in a practice enrollment model, then certainly, and we are being more proactive about that right now, go through your roster and make sure that that you've made this an option for your patients to be able to enroll in your practice. Because if they're enrolled, it doesn't matter whether they've been seen in the last 24 months or not, you can still bill comprehensive care. If you have a patient in your practice that's refusing to enroll, or you're in a practice that doesn't that doesn't involve enrolling patients, that's difficult. And hopefully you can convince the patient that there is good reason to try to see them in person within the past 24 months. But again, it even comes down to an equity issue. Like some patients might have trouble doing that. I don't know if they refuse to come in and they demand a virtual visit, if they can, I don't think you can bill them on top of that. So it puts us in a bit of a bind, honestly, and I think we'll have to see how that plays out.
Yeah, I would agree with you. And my understanding of the billing rules as well is that you couldn't charge for that because it's an OHIP covered service. So you're right that you would essentially have to, go with the OHIP code there.
And also just address it with the patient. What's the problem? Why is it that they're not able to come in for an in-person visit, and maybe try to help them with that? It's good to see our patients in person every once in a while. And if a patient really isn't agreeing to come in 2 years, that you got to think like, what's going on there? And maybe you can help them somehow.
And I think that dovetails well with this next question, because I think that this does happen quite a bit, and certainly virtual care has accelerated that, which is, patients who, were living quite far away from the practice. And during that era where there was so much virtual care, it didn't really matter, right? And now all of a sudden there is this, need for patients to come in person much more. And so, there's a physician here who's asking a question around, they have actually patients that are in another province, and, what should be done at this point, because they've been following them up until now, and whether there's any, issues or considerations for that.
Yeah, great. So, I'm in a patient enrollment model system, and I have patients all over the map now because they move away and they usually can't get a family doctor. I like to think it's because they like to continue the relationship with me, but it's a bit of both, hopefully. And that's not a problem because they're enrolled in my practice. So I don't need to try to pull them in. Patients that are out of province, though, again, controversial. Like, why is there a difference between Billings and CPSO and CMA? But towards what you just said before, Ali, that's now not a service that's covered under OHIP. The OHIP says we're doing a virtual visit and they're not in the province. We can't bill OHIP for that. And so I do think there's an option there to bill them for the visit outside of OHIP.
Thanks. That was my understanding as well. So it's helpful to get that confirmation. Thank you. So next, actually, there was a really interesting question around private virtual care for pay. So I believe this was a comment that was in the chat, that there are some companies that seem to be doing that, where they are charging for virtual visits now. And I'm curious if you've come across that, and could comment a bit about that.
Honestly, I haven't had direct experience with that. I've heard that this exists. It's not that issue goes beyond virtual care. That applies to in-person care as well. And I have patients that go to private clinics to get through their company, and they get their full physical examinations done, a lot of which would be covered by OHIP, but then they kind of go over and above with what we would consider clinically indicated or as per guidance, and they're paying to get all this stuff done when they could be coming to see me to get the stuff that we're recommending done. It's the same with virtual. I don't think there's a difference really. They can do the same and pay for whatever they like virtually. Whether that's better for them or not, I think it's obviously, I'm an advocate for the system that we're in, and I hope that we can provide them with services to the extent that they don't need to do that.
Thanks so much. So our next question here relates to, I guess, some of the billing nuances with virtual care. So the question is, does a phone appointment require some kind of physical exam in order to bill A001 or A007? Or is it that if we deal with more than one problem in a call, can we bill the A007?
Yeah, good question. You don't need to have the physical exam part as part of the assessment. And in terms of whether, sorry, the second part of the question, could you just say that again?
If you deal with multiple issues, does that automatically
qualify for an
A007?
no. To me, that's been a misunderstanding all along. When I was a long time ago, I thought if the difference between an A007 and an A001 was if you have more than one problem, but that really isn't in the schedule of benefits anywhere. It's the schedule of benefits has very well defined criteria for what qualifies for an 8001 and 8007. And aside from the physical exam, you have to meet all the same conditions, whether you're doing virtual or in person. And just by the way, there's a lot happening with physician-directed patient self-examination now. And we were kind of winging that at the beginning of the pandemic, but it's becoming more and more of an evidence-based science. So it's the standard of care is now moving towards us being able to direct a patient to examine themselves for certain conditions. There's some really good references for that, and I can pop some of that in the chat after the question and answer right now.
Great, thank you so much. So the next question comes from Dr. Rosemary Lal. And actually there's quite a few questions about this in the chat as well. Is wondering if you could speak a bit more to the phone system that you had mentioned, the soft phone, that allows you to use your phone and show the office number at the other end.
Yeah, that's made a big difference. Thanks for the question. So it really was a problem. You know, even patients that had booked appointments for me to call them, they have a thing on their phone that would just block my call if I'm not showing my caller ID. Obviously, I don't want to show them my personal cell number. And if I'm working from home, that's what we do. So it was a problem that, or they wouldn't recognize the caller ID and because it was blocked. So I was actually missing visits because they weren't picking up. So we did install a system. It's in the references there, the one that I use, but there's lots of choice. There's, you know, we've gone from phones to smartphones to soft phones. A soft phone is actually a phone system that runs on a device like a smartphone or a computer. And it allows me to, when I'm on my cell phone, rather than calling just directly from the phone as usual, I open the app and call from the app. And you can program that app so that the person receiving the calls sees the caller ID, in my case, as my office number, and they know it's me and I can pick it up, and they pick it up. And the other part to that also is we can use the same system so that when patients are calling into our office, we can direct those calls to anyone's personal cell phone number also. So it made it really easy for our staff to work from home. And some of them still do. We're still doing some kind of balance between in person and at the office and at home. So if a patient calls an office line, we can have a receptionist who's working from home that afternoon, have the calls go right to their cell phones too. So that was in the reference, that last one. The one I used is called IPfinity, but Cloud Voice, but there's lots out there.
Wonderful, thank you. And I believe you included a link to that too in your references there. So hopefully our participants can take a look at that after. And I see some others are sharing their own ideas too, and that's wonderful. So that's great. Next question I wanted to ask. Oh, it looks like it was already answered. Oh, yes, sorry. The last question was just around why, and this is from Dr. Viren Butt, why is FaceTime or WhatsApp video not approved for video visits?
Yeah, good question. So I'm actually I work with Ontario Health on the Verified Solutions Advisory Group. So we've created a minimum set of criteria that need to be met in order for these systems to be verified. Obviously, privacy and security are a big part of that. Functionality also factors into it. And it's really quite new. I mean, we've only been doing this for the last months to a year or so. So first of all, there are some systems that just haven't gone through the process yet. Now it's really going exponential, especially with what happened December 1st with the new rules. So we're really picking up momentum on getting these processed. So there's a chance that a system just hasn't gone through the process yet. It's a very efficient process. And then secondly, some of these systems really do need to tweak something here and there in order to meet the criteria. Obvious things would be, you know, if they hold their data outside of the country, that's not okay from a HIPAA point of view. So there are certain criteria that even the big organizations do need to meet to comply with our Ontario Health standards for what we need. I don't think it's going to be a significant problem for most organizations, and there is a process. if they don't initially meet the criteria, we work with them, and we can usually resolve these issues. So far, they've been relatively minor. Once they get verified, that's through attestation. So basically, we make sure that they have met the criteria from what they can show us. But then once they've been verified, they actually have to be validated. And that process goes from Ontario Health to Ontario MD. So once they've been verified, they have, I think, a year for Ontario MD to actually run some tests and put it, use the system and make sure that it does what it needs to do to meet the minimum criteria. If a product doesn't get initially validated, again, there's an allowance for turnover time, so you'll be able to keep using it as a verified system, but they do need to meet that criteria as well. And there's a reference to the list of currently verified systems that I put in my references.
Wonderful. Thank you so much. And that's great to hear that you're involved in that process, because I think people appreciate that explanation. So thank you for that. So just being mindful of time, I think we're going to move to our next speaker. But Dr. Samson, if you don't mind, there's actually quite a few questions in the Q&A that you can answer like through text-based method. And I think actually people might really appreciate it, and you have so much wisdom on this. So hopefully your questions can be answered that way.
Absolutely.
Perfect. Thank you. So we'll just bring the screen back up, and I just wanted to highlight this resource here from the Ontario Medical Association, which is a virtual care billing visual guide. It can be quite helpful when you're trying to determine, do I have a comprehensive relationship or not, and what codes am I eligible to bill? It lays it out a little bit more clearly. So definitely recommend taking a look through this resource, and you can access it through the OMA website and at the link that's there. Next slide. All right, so it gives me great pleasure to turn things over to the co-moderator, Dr. Tara Kiran, to speak about Care Canvas.
Hi, everyone. I think as we're talking about how to be efficient in practice and ensure that we can focus on the patients who need our care the most, I wanted to introduce this new tool called Care Canvas that we've developed. It's basically an interactive dashboard that takes data from your EMR and summarizes it so you can see kind of how you're doing when it comes to quality of care you're providing. Maybe I'm going to get Olivia actually to just show you a demo of Care Canvas, and I'll tell you more about it. What's exciting about it, maybe Olivia, you can start at the practice profile page if you go to the left there. So this is the landing page here. And what's great about Care Canvas is that it's really been designed by family physicians for family physicians. You can see here, we focus on your rostered patients, and we can tell you, for example, the proportion of visits that you have that have been virtual and how many visits you've been seeing. We can give you a breakdown of kind of the age and sex of your patients. And then if we also talk about your the income quintile distribution, so what neighborhoods your patients are coming from, we can find, you can see a map of your patients, and then at the very bottom of this page, you'll also see how you're doing in terms of chronic conditions. And Olivia, if you scroll back up a little bit there, you're going to see here these buttons, my patients, my group, utopian. So you can actually compare yourself and how you're doing to other practices. So other physicians in your group, but also other practices that are outside your group as well, and how your patients fare. I'm going to go to the next tab, which is diabetes. You can see on the left-hand bar, there's a menu, and those are all of the kinds of quality of care indicators that we're able to provide to you: diabetes, high blood pressure, opioid prescribing. We've got information on benzodiazepines and antibiotics, as well as immunizations, including childhood immunizations. All of this from your EMR. This page, I'm just going to walk you through a few key aspects. So we'll stay at the top here, Olivia. And you see at the diabetes, we've highlighted right at the top some of the key things you would need to take action on. So on the left-hand square just says the number of patients that aren't meeting blood pressure targets, and then the number of patients in the middle whose A1C is above a certain target. So these are patients you may want to act on. And if you click on the download follow-up list, you would get actually a CSV file that you can download that has patients' EMR IDs. And Olivia, maybe you could just click that button for me, click the download follow-up list. And you can see here, these are the kinds of things that you could download. So if you close that window, Olivia, we'll go back to the main dashboard, and we'll keep going down here, and we'll scroll down further, and you can see the kind of data we provide. So for example, you can see patients, how you're doing, and you can go a little bit further, and we can focus on glycemic control here, and we can see that what proportion of your patients have an A1C, in this case under 8.5, but you can actually toggle the A1C value and see under 7. Olivia, can you press change over time for me? And then you can see how you're doing in terms of meeting that target over time. Olivia, if you can press age, you can actually stratify that by age. And yeah, if we can go to the A1C toggle button there at the end, you can see here, you can choose how you want to display things. So if we go we can see if we could scroll all the way to the end there, Olivia, we actually have at the bottom as well. So we talk about blood pressure and statin prescribing. You can see what proportion have a smoking cessation documented. And then at the very bottom, we've got some resources, and our team has done a great job, I think, really trying to highlight resources that we think are helpful to you in the clinical office when you're caring for patients with diabetes, and the resources that you can provide for patients. And you can actually download these list of resources. So, that's just a preview, and you can actually see more of this preview on our website, carecanvas.ca. I guess the important thing here is that anyone in Ontario who uses Accuro, TELUS Practice Solutions, or OSCAR is able to sign up for a dashboard through your local practice-based research network. So in Toronto, that's Utopian, but it's other practice-based research networks across the province. There's information on carecanvas.ca about how to sign up. Our next dashboard will be coming out in the spring, but you do need to sign up before December 31st in order for you to get the dashboard in the spring. So thanks, Olivia. You can end the demo now. And yeah, Alan Grill, you're right that this is a great tool for you to support your CPSO QI project. It's also actually a great way to earn Main Pro credits. So you can actually earn 6 Main Pro credits just for reviewing, for example, your patients with diabetes whose blood pressure is too high, for example. So a great way to earn Main Pro credits while you take care of your patients. So thanks, everyone, and happy to answer more questions in the Q&A or in the chat. Back to you, Ali.
Thank you so much, Tara. And I just really want to throw my endorsement behind this. This is a fantastic resource and program. I found it's already been so beneficial for my patients as well and my colleagues. So definitely encourage everyone to check this out. Let's move on to the next slide. So it's a great pleasure to turn things over to Dr. Chagla.
Hi, everyone. Thanks for having me. I am going to keep my comments pretty brief, but just going through some updates in everything that's been going on with COVID vaccines and therapeutics. And I think there's a lot of questions about Paxlovid very reasonably. So we'll try to spend the bulk of time kind of teasing through the indications. So, with vaccines, obviously there are lots of vaccines available for use in Canada. The primary series is still either Moderna, the original vaccine, Pfizer, the original vaccine, Novavax, which is available as a primary series and a booster, and Johnson & Johnson, which is largely unused. Boosters that are available now in Canada are the Moderna BA1 or BA5 vaccine, the Pfizer BA5 vaccine, and the Novavax vaccine that is also approved as a booster. One of the updates that has come down the pipeline and will be available on, I believe, December 21st is the Pfizer BA5 vaccine will be available as a booster shot for children between the ages of 5 to 11. The NACI guidance really to prioritize children at the highest risk, but everyone may be able to access the shot. And then the other update that came this week was that co-administration for all age groups was acceptable for other vaccines. So previously, in an abundance of caution, there was a caution for co-administration or a recommendation to delay co-administration in that 6 months to 5 years age group. That recommendation is now gone in an attempt likely to increase the influenza vaccine uptake in children. And so the vaccine, the 6 month to 4 or 5-year-old vaccine can be co-administered with the influenza vaccine. So lots of good updates, streamlined and making it simple. And again, the availability of the BA.5 vaccine for a booster shot for children between the ages of 5 to 11, still unclear of what's to come for 6 months to 5-year-olds in terms of booster vaccinations with the bivalent vaccine. Next slide. So, one of the big questions has come up in terms of how do these bivalent vaccines perform on the real market and in real patients. I will say studying this is really difficult now in the consideration that a lot of people have had COVID one way or another with or without a vaccine. There's differences in people in terms of how many vaccines they've had, how much COVID they've had, how much of both they've had. And so judging vaccine efficacy is going to be a lot different than 2020 when it's either, you've never had COVID and you got a vaccine. So these studies are really modeled and use a lot of assumptions. There is a lot of biases introduced, and so these aren't perfect. This was a large US study that looked at people testing at pharmacies with PCR, and again, you can always see that there may be some biases there in terms of who gets tested, symptoms, that type of thing. But they compared people who they suspected were unvaccinated. Now, unvaccinated could be and based on US data is unvaccinated. Oh, go back one, sorry. Unvaccinated here is people that likely have had an infection over time, considering the US seroprevalence. But the bottom line here is we see that there is somewhere between a 40 and 60% efficacy of the bivalent vaccine in short-term prevention of symptomatic COVID-19, so prevention against infection. The big caveats here is that it tends to be better with the lower number of doses. So 2 doses, so people who had 2 doses than the bivalent seem to perform better than people that had 3 or 4 doses. And that may be teased out by when they received their last vaccine. So the analysis on the right really says how many months has it been since you received the vaccine, and you can kind of see this trend here. The longer it's been since you've received your last vaccine, so when it gets to 8 months or 6+ months, you're starting to see numbers in the 40-50% range, whereas people who got vaccinated very quickly after their last vaccine, so 2 to 3 months, the efficacy is a bit lower. And so again, this recommendation from NACI really at 6 months actually holds pretty well, I think, in the context of everything, and really keeping people up to date. This doesn't necessarily mean that high-risk patients shouldn't be getting their doses a bit earlier, but for the general population, it may be worth it to, again, wait that 6 months, as the biggest bang for the buck for these vaccines seems to come there. Next slide. This is UK data, and again, this is based on the UK Health Services Agency, looking at the BA.4/5 wave. The UK actually, so the US used a BA.4/5 vaccine as their primary rollout product, the ones that kind of came to the market later in Canada, whereas the UK used a BA.1 vaccine, which is the product that came to the market earliest in Canada. And so these are patients that received at least 2 vaccine doses, with the last dose being greater than 6 months ago. And they compared it to those who had received, the 2 doses of vaccine. So, as an incremental efficacy based on their peers who didn't receive a bivalent vaccine. And they saw the protection against infection to those with that are 6 months out from their last vaccine was 57%. So, again, a case to be made that there is some short-term protection against infection. This is 2 months of data. So, early data, we don't know what this looks like in 3, 6, 9 months. But again, that those patients that are eligible, particularly patients that are receiving that 6-month point from their last vaccine, probably do derive the biggest bang for the buck from these bivalent vaccines. And those are the ones that I think in real life practice you want to continue to get in, especially if they're high risk, as they may get significant benefits from boosting, especially at a time when transmission is high, as we're starting to see again in that sense. Next slide. So bottom line, there are some benefits to preventing infection. I think for high-risk populations, not having COVID or not having COVID again is still an important thing. There's no data yet on prevention against hospitalization, but I think looking at 4th dose data from Israel and other settings, the US, even if this vaccine acts as good as the original vaccine for 4th doses, there's still going to be that protection against hospitalization that was seen. And so there's nothing to doubt that there's going to be significant protection against hospitalization. The one, caveat to all of this is we're not necessarily in a BA4 or 5 era. The current variants are BQ1, BQ11, XBB, and a bunch of others that are a bit more immune evasive. And so those do take a little bit of a bite out of vaccine efficacy. But again, I think, the high-risk folks, particularly people that are reaching that 6-month point since their last vaccine, they're certainly still deriving benefits from these vaccines and should be really targeted as part of campaigns moving forward. Next slide. So therapeutics, this is obviously the hot topic with what's happened on Friday and Monday of this week. So I'll talk about Paxlovid for the most part, and then Evusheld a little bit at the end. Next slide. So these are changes as of December 12th. So number one, there's pharmacy prescribing of Paxlovid. This is being done, across commercial pharmacies. Same kind of test criteria, so PCR, rat test. Pharmacies also have the ability to do them on site, and really, a scope that includes, certain patients, particularly where drug interactions are minimal or there's a minor substitutions or additions. It doesn't mean that every patient can access it through this pathway, especially patients who are on critical medications that have significant drug-drug interactions. And so, it's a great option for patients. It will help for sure. I think the pharmacists are engaged, and this has been really piloted in many different provinces like Quebec and Alberta with reasonable success with a limited scope. So that's great. The enhanced criteria here, and I think are the controversial point that I've seen in the chat quite a bit, is that the criteria are much more broad than they were before. So this is now anyone over the age of 60, anyone over the age of 18 that's immunocompromised, and those are pretty close to how it was prior to last week. But then we have this 18 to 59 at higher risk of severe disease. And that includes people with a comorbidity, and I'll put the comorbidities on the next list. And those who are inadequately immunized, either didn't receive their primary series or didn't get a vaccine at all, or have been quite a bit of time since their last dose of vaccine. And again, there is some discomfort here that an 18-year-old that didn't get their last, that got their booster shot in January of 2022 would be eligible for Paxlovid. And I'll talk a little bit about where we kind of see risk in this context. There will be an evidence brief on these criteria, I think, coming in the coming weeks. But I'm not on the panel that made this decision. I'll talk about where my opinion is as the patients to target based on what's come out in real life evidence and kind of number needed to treat in that sense. Next slide. So these are the underlying medical conditions. These are from the federal government, but were linked in the Ontario Health document. And you see, basically most comorbidities, chronic liver, lung, cardiovascular, neurologic disease, diabetes, disabilities, mental health disorders, which is new. There is good data to suggest the burden of mental health disorders does independently increase the risk of severe COVID-19 outcomes. So not unreasonable. Pregnancy, immunodeficiencies, a smoker, even current or former, and immunosuppressants and TB. So, some of these I think are slam dunks, like immunosuppression and cancer and CKD and severe bronchiectasis or COPD. Others, I think are a little bit on the edge of really how much risk and benefit is there, like a smoker, a former smoker, or an otherwise well person with mild obesity. But again, I'm going to talk about how the real life data has translated and making that as part of your clinical decision making. So next slide. So this is data from Ontario, which is great because it helps reflect what we've done over the last 6 months. And so this is a cohort-based study that was done by my colleague Kevin Schwartz at St. Mike's. They looked at people who got Paxlovid from April 4th to August 31st. So this is really where we use that criteria of over 70, under vaccinated, either over 60 or with comorbidity or immunocompromised. and so what we've been doing kind of prior to December of 2022. They looked at hospitalization and death in the group that got nirmatrelvir ritonavir versus an unexposed control that had the same criteria, and they saw a 50% reduction in hospitalization and death with the 95% confidence interval that was statistically significant here in hospitalization. And again, the risk of death was significantly also reduced. Now, I want to direct you here, and as we frame the conversation of who should get Paxlovid, into the numbers here particularly. So when we look at that that high risk control group, the people that didn't get nirmatrelvir ritonavir in the old criteria that we used prior to last week, we see about a 3.7% rate of hospitalization and a 3.3% rate of death, which we about half with the use of nirmatrelvir ritonavir. And the number needed to treat in this study was about 62. So, I think we're doing due diligence here. Treating 62 patients is actually quite a bit. We also know that, again, looking at this data, that even of these high-risk patients, 96% of them will do enough to not need hospitalization. And so there is a as you start getting down into slightly lower risks, there is a diminishing reward in that sense. And so a number needed to treat of 62 is actually reasonable. In the original EPIC-HR study that got Paxlovid was closer to a number needed to treat of 25. So really reflecting, more immunity, more vaccination, probably less virulent variants, but, some benefit here. And these were same across strata of age, DDIs, vaccine status, and comorbidities. And so, that old criteria, I think, hold pretty true that they do prevent hospitalization. The number needed to treat was about 62 with the old criteria. And so those are still patients that we really do need to focus on. Amongst the new criteria that settles is that these patients that are in the old criteria, older, with a medical condition, under vaccinated, immunocompromised, that are at high risk. Next slide. This is some US data that actually came out this week that really talks about where these new criteria may end up. And so in the United States, the criteria actually have been pretty similar to what Canada or what Ontario is currently moving into. And so, in this study, they looked in a big observational cohort. I think this was done in Boston and a couple of eastern states. And looked at people who got nirmatrelvir ritonavir versus placebo. They tried to control again for things like immortal time bias and confounding by indication, especially patients who have DDI who may be excluded from this type of study. But they saw benefits. They saw about a 50% reduction in hospitalization. This is patients over the age of 50 that were studied in this cohort. But the one thing I'll bring you to here, and it is a little bit small on these images, is the control group. The baseline risk of hospitalization in this control group was 1%. So, as compared to that Ontario data that we saw in the last slide, where we used a more tight criteria, saw hospitalization risk close to 4%, this US looser criteria of just even 50 and older still only had a hospitalization risk of 1%. And in fact, the reduction of hospitalization was about to 0.5%. So about a 0.5% absolute risk reduction, which translates to a number needed to treat of 200 to prevent one hospitalization. And so, I think this is where this discussion comes up. There are, people in that low risk criteria that are now being pivoted to, where their number needed to treat to prevent a hospitalization is going to be 200, 300, 400 in that sense. And so, partly, I think we obviously are diligent to patients. If they request it and they fit criteria, you can have a discussion with them. But I think there is some data to suggest, yes, they may benefit, but they may benefit from a hospitalization risk of 0.5% to 0.25%. When we talk about stopping and starting medications, GI side effects, dysgeusia, which is quite bad for some patients when they take it, you do have to have a meaningful discussion with these patients in terms of what that means for them, and ultimately let them make that choice. But as we start getting to looser criteria, I think you can probably quote these patients at 1% risk of hospitalization as the baseline in that sense. And so, if you did nothing, you'd have a 99% chance of not being hospitalized. In, again, the looser criteria, not the over 70s, not the immunocompromised, not the people that are under vaccinated. And you can see in the subgroup analysis in this study that people who were under vaccinated did the best with Paxlovid. People that had their last vaccine a long time ago did the best with Paxlovid, and people that were obese did the best with Paxlovid. But, again, when you start getting to the 18-year-old diabetes, which I think was a mention in the question, you probably can quote that, yes, they may benefit, but the number needed to treat is so high here that it's unclear, in a population, if they're really going to benefit that much, and balancing that against the side effect profile of dysgeusia and GI side effects in that sense. Next slide. So, again, it is available. I don't want people to think that the supply is minimal. It isn't. There's, I think, 1 million doses that were ordered by Canada, and considering, I think, about 10% of that has actually been distributed and implemented, there's still a large supply. But, I think the discussion with patients can be around number needed to treat, and especially, particularly if, A, there's time resources to counsel these patients, but B, when you're starting to make drug changes that may, incur risks and benefits in that sense. If lower risk and they can't take it, it's okay. The risk is low. You can counsel them. The risk is low either way, and leave it at that. We clearly didn't treat these patients prior to December of 2022, and certainly I have not seen in clinical practice a lot of 18-year-olds who had 3 doses of vaccine who haven't gotten a bivalent that are admitted to hospital with severe COVID-19 in the ICU. I will say remdesivir is still available. The guidance from Ontario Health for the lower risk criteria has been really Paxlovid focused. Remdesivir is incredibly resource intensive. And so most centers, including our own, will reserve it only for high risk individuals where the benefits would outweigh the risks. So, we've been largely using it in transplant because of the DDIs. We'll use it in, patients with dementia with pill swallowing issues or other things. But, I think if you have an 18-year-old diabetic that has a major drug interaction with Paxlovid, we probably would not offer them remdesivir as it's just too resource intensive for the benefit. Next slide. Lastly, Evusheld. So Evusheld is a 2-component monoclonal antibody. It's been administered in Ontario since May of 2022. The initial criteria were for transplant and hematologic malignancy, and then recently, as of September, people on B-cell depleting agents were also added to this list. And again, at the time, variants of concern were very susceptible, and so was a good option for patients as an adjunct to vaccination. Next slide. This is actually some of the data that came out in the kind of new variant period, where there was a marked reduction in infection, which is great, but also marked reductions in hospitalization, ICU mortality, and COVID mortality in a global, again, retrospective cohort. So there is some grains of salt in here, but in a high-risk population, seeing remarkable benefits on top of vaccinations in that context. Next slide. Unfortunately, with the novel variants, so BA.646, BA.2752, BJ1, BQ11, we are starting to see the neutralization of these antibodies. So tikexivimab, silgevimab are the 2 here that make up Evusheld that are starting to become very unreassuring in that context. And so Health Canada put out a notification about a month and a half ago talking about that, efficacy may be markedly reduced in people. And then Ontario Health, as of Monday, put out a statement really saying that this is not recommended outside of clinician individual context. So a clinician can make the decision with that patient with caveats in mind. So next slide. So this is now not recommended for routine administration in Ontario in those risk groups that we knew. Clinician discretion can be given for individual patients that may benefit, but the higher dose needs to be given. So the typical dose was 150 is now 300. They must follow public health measures or be counseled to follow public health measures and not use this as a way to kind of reduce their risk behavior if they are patients that are at high risk. That they're warned that this may not be useful or may not have as the efficacy has been advertised in clinical trials, that they should should get available vaccines, and in fact get every available vaccine prior to getting Evusheld, and that when they do become symptomatic, they should immediately seek care and treat and testing and prioritize treatment in these high-risk groups. And so we are an Evusheld center. We actually have given out a lot of Evusheld, and we're just slowly taking it offline to retool a bit and then and bring on these criteria and let it be at clinician discretion to advertise. And we've reached out to kind of our high-risk immunocompromised providers to kind of give them this information and prioritize certain patients who they think, even a minor benefit may be something in that sense. Next slide. And this is my take again, I don't sit on any committee. Neutralization is an in vitro phenomenon. We look in the lab, we see how well antibodies bind to virus, and we kind of use that as our measure of efficacy. Interestingly, sotrovimab, which is the monoclonal antibody we used in BA1, when we looked back, so it was withdrawn in Ontario, as many know, during during BA2. When we looked to countries that didn't withdraw it, so the UK in particular, which actually still is a standard of care in the UK, their data for BA2 suggests there was no loss of efficacy in hospitalization. And so, there is maybe a little bit of an overcall just relying on neutralization as the measure. We know antibodies do different things in the human body, not just bind to virus. And so, it may not be the perfect measure, and we may be overestimating the loss of efficacy in that context. These patients are super high risk, especially, transplant, hematologic malignancy, and B-cell depleting patients. And so, again, if you can offer, we think that neutralization is imperfect, and maybe it's, 20% benefit for these patients in terms of preventing an ICU, that's still something for a patient that has to live with an ongoing risk of severe COVID-19. Not to say that that patient still should follow all those steps and still should get tested and treated appropriately. There's not many side effects. And again, it's pretty easy to administer. And so, I'm not totally convinced. I think, when we talk to our providers, they're really focusing on some of the elderly immunocompromised patients, some that have gone through intense immunosuppression, where, even if there's a minor benefit here, that they would rather have the patients have a minor benefit than not in that sense, and just going through the counseling appropriately. I think that's my last slide, and I'm happy to take questions.
Thank you so much for that really detailed and efficient overview of all the different literature and the nuances there. So quite a few questions here, and I'm mindful as well of time, so we'll probably do about 5 minutes or so of questions, and then move to our next speaker. So the first question is whether pharmacists have access to lab results to look at renal function, and how critical would you say this is for younger, healthier patients who want Paxlovid, from Dr. Danielle Manis?
Yeah, that's a really good question. So some pharmacists do have kind of some of the, whatever the portals are, Connecting Ontario, Clinical Connect, or whatever. It's not all of them, though. I would say, in our clinical practice, I don't know what it's been for you guys, we prescribe a lot of Paxlovid. I've used a lot of clinical judgment in terms of dosing in that sense, and considering that bringing a person in, getting a creatinine done is a huge barrier for a therapy, and we start many other medications in patients with without checking their renal failure, even renal function, even though they can lead to renal dysfunction very quickly, that just use your clinical discretion. The NIH guidelines kind of use that. If you think this person has renal dysfunction, you should check your creatinine, which I think is a good lesson. If that person looks really sick in front of you, hasn't been eating or drinking for days, and is on multiple renal toxic meds, maybe you should check their creatinine. If they're a healthy 40-year-old who's on a biologic that feels okay and has a runny nose with their COVID, you probably don't need to know what their renal function is in that sense. So I think, as with anything, use your clinical discretion, basically.
Awesome, thank you. And then the next question comes from Dr. Korn. Let's say there's someone who's in day 3 or 4 of their COVID symptoms, and they're mild symptoms, but they are over the age of 70. Would Paxlovid be worthwhile in a patient like that?
Yeah, I think so. Look, I think that data from Kevin Schwartz in Ontario is pretty compelling, that you do see a reduction in hospitalization. Even in the registration trials for Paxlovid, they didn't necessarily differentiate symptom severity in terms of benefits. They really, differentiated, symptomatic or not symptomatic as the criteria for admission into the trial. So I think if you have symptoms, even if they're mild, I think use your clinical judgment. If they're all over their symptoms by the time you're seeing them, maybe you can make a judgment to not use Paxlovid in that context. But if they're still symptomatic, again, you don't want to see progression a week or two later where we start seeing it. It may be worth it if they fit that high risk criteria, knowing that the aggregate data suggests that there's still significant benefits in that population.
Thanks so much. Next question's from Dr. Blinick around whether Paxlovid should be used for a patient recently treated with Paxlovid that then has a rebound recurrence of COVID.
Yeah, so the guidance is no. I will say the only group where we may make individual considerations is where they have severe immunosuppressive states, or they're not clearing their virus very well, where we may make some individual decisions. Generally, the data around rebound is coming out more and more now. It's about an 8 to 9% rate. It's interesting, though, that prospective studies looking at rebound show that 8 to 9% rate regardless of what therapy they receive. And so, again, I think we worry about rebound. One course of Paxlovid still reduces the risk of hospitalization in multiple observational data sets. And so, in most individuals, if they experience a rebound, just let them settle out. And the data suggests that they're still at marked reduced rate of hospitalization.
Thanks so much. And then our last question I'll ask you live is from Dr. David Dane, which is, what is the number to harm with Paxlovid in low-risk patients?
Yeah, it's a good question. There is a rare risk of hepatitis. I think it's quoted at 1 in 1,000, so that may be where you judge. The rest of the side effect profile is pretty minimal. We see GI and dysgeusia, and dysgeusia is almost 100%, so you kind of have to take that in the context. I think when you start introducing medication adjustments, you start getting into a number to harm. And so that's an important piece too, especially if you're stopping critical medications. You really do want to consider that. And so it's not perfect. I would say, 1 in 1,000 is probably the serious adverse events to lead to hospitalization. But, when you're getting into med adjustments, it's probably a bit higher than that, basically.
Great. Thank you so much. And again, there's quite a few questions we didn't get to in the Q&A. So Dr. Chagla, please feel free to respond to those there. Thank you so much for your talk. So next, I'm going to turn things over to Dr. Danielle Martin, Chair of the Department of Family and Community Medicine.
Good morning, friends and colleagues. Thanks so much for including me in today's community of practice. It's December and we've all had quite a year. And so we thought it would be useful to spend just a few minutes thinking a little bit about what the role of primary care has been in the pandemic in Ontario, and to reflect a little bit on all that we have been up to as a discipline over the last period of time. Next slide. This is a very brief overview of a few of the key messages that arose in the COVID-19 Science Advisory Table brief, a 3-part brief on the role of primary care in the pandemic, which was authored by a large group of academic family doctors and nurses, nurse practitioners, pharmacists, and others from across the province of Ontario. Many of those authors are on this session, and so I just want to acknowledge this is not my personal work. I was involved and engaged in the writing of the briefs along with many colleagues, and you can read or skim the full 3-part brief at the Science Table website and see the full list of authors there. Next slide. So why should we care about primary care? This slide speaks to the ecology of care in the province of Ontario every single day. If you think about how much time gets spent in the media and in the minister's office worrying about the wait times for hip and knee replacements, just as a small example, and not to pick on our orthopedic colleagues, but there's 130 of those happening every day in the province of Ontario, in contrast to the 161,000 visits to a general practitioner or family physician in the province of Ontario. And so we should care about primary care because most healthcare in Ontario is delivered in primary care, and because we know that health systems with strong primary care yield better outcomes, are more cost effective and more equitable. Furthermore, just a reminder that almost all COVID-19 care takes place in the community. And, happily so, we're so glad that most of our patients don't get admitted to the hospital with COVID. But what that means is that although the narrative is often about ICU beds, hospital beds, emergency departments, hallway medicine, et cetera, all of which is important. In fact, most people with COVID-19 are receiving their care from their family physician, their primary care clinician, their primary care team, and certainly the management of long COVID, the pandemic peak in mental illness, the fall surge of respiratory illness, the management of patients who are waiting for specialist care and experiencing delay and deferral. All of that comes to all of us in primary care. So if you feel busy, that's why. You are busy, and most of the care that's happening for the people of Ontario is happening in primary care and family medicine in this province. Next slide. So what have we been up to as a discipline? Primary care clinicians and family physicians in the province of Ontario have had a huge list of new work, as have our colleagues in other disciplines as a result of the pandemic. And this slide summarizes nicely in an infographic what we've been doing. So new work has included COVID-19 assessment, testing, support, all the work related to vaccines, all the therapeutics that we've just been talking about, the work of management of long COVID, family physicians in particular, but other healthcare providers as well, moving into emergency departments, intensive care units, long-term care, providing education to our general population, not only to our own patients, and of course, the maintenance of non-COVID care and mental health services. And so, all of this is supported by evidence and consistent with what's been happening internationally. And there are nuances in that much of this work in Ontario related to testing and vaccination have occurred outside the primary care office, which is in contrast to some other jurisdictions. But nevertheless, it's new work and it's been done by the same workforce. Next slide. So how much have family physicians, this slide is particular to family physicians, it's ICES data looking at volumes of care. And what you can see is following the acute drop in services that came with the medical officers of health's recommendation to move to essential care only, there was a quite rapid rebound and recovery to pre-pandemic levels. So the volume of visits in family medicine by family physicians in Ontario has been back up at pre-pandemic levels for quite a long time. And that is, of course, a combination of virtual, which is the red bar, and in-person, which is the dark blue line. And so, nobody knows what the right combination of virtual to in-person is, or what the right ratio is. And we've been talking a lot about the role of virtual care with Kevin's presentation today. But just to say that those volumes have been back up to pre-pandemic levels for quite some time. Next slide. And to add to the data regarding the volume of work, most of the, across all models of compensation, whether you work in a FO, a FIG, whether you're on fee-for-service, et cetera, that the volume of care being provided in terms of days worked has been increased across every model of compensation compared to pre-pandemic. So this implies, or one might infer from these data, that additional work being done for COVID-related services has been in addition to, rather than instead of, routine care. Next slide. And now we find ourselves in a situation where, of course, the system is under incredible strain. Our patients are under incredible strain, dealing with the impacts of deferred care, waits for specialty care, chronic conditions that we now need to try to help them to get hold over, issues relating to mental health and addictions. All of this is falling on primary care. And so the sense, in addition to the very significant human resources strain that we feel that that our system is under. If it feels like it's stressful, I think it's because it is, and we need to acknowledge that, at the same time acknowledging the incredible work that is being done by primary care clinicians and family doctors across the whole of the province. Next slide. And so the lessons learned, and this is the final slide of my presentation, are outlined in some detail in those science table briefs for those who want to take a quick look. And I will say that these briefs, which summarize a huge amount of evidence, really speak to the critical importance of relationship-based, longitudinal family medicine and primary care. That the evidence from our pandemic experience in Ontario supports that care in a formal relationship, a formal attachment relationship with a primary care clinician provides better support, that team-based care has been more effective and therefore should be expanded, that trade-offs have necessarily had to occur over the course of the pandemic, but that a huge amount of innovation has also occurred. And I think that we can really leverage our long-term relationships with our patients and our communities to try to continue to respond to this public health crisis. And I just want to assure all of you that the amazing work that's being done in family medicine and primary care in Ontario shines through in the data and in the evidence, and that the importance of those relationships that we have with our patients and that we can build even more effectively in team-based care with formal attachment relationships to the population really stand the test of a public health emergency. So for those who are interested, I'd invite you to take a look at those science table briefs and to use that evidence in the advocacy that you all do in your media work, in your conversations with your local MPP, to really emphasize that we could not have gotten through these phases of the pandemic thus far without access to family medicine and primary care, and that we will not get through what is to come unless we expand access to high quality primary care in the province of Ontario. Next slide. And with that, I'll hand back to you, Ali and Tara.
Thank you so much. And I think that was such a perfect way for us to close out this year's community of practice sessions as well, to hear about all the incredible work that we're all doing. And it's really nice to see in the chat too, like so much sharing around everyone's mutual experiences and the fact that we've all been living through this, but to actually see it represented in the data, I think is so validating and something that we all need to champion and bring forward during this time. So why don't we take a few questions here? So let me see here, Danielle, I just want to try and make sure we find some questions for you. Okay, so this one's a little bit out of left field, but it's around the family medicine residency and the extension potentially of the training program to 3 years. Are you concerned around this particular change, and will that longer residency potentially deter people from selecting family medicine?
Yeah, so it's a great question. The College of Family Physicians of Canada has announced its intention to move to a 3-year family medicine training program in Canada, which will put us in line with most other countries. So we do have the shortest residency with the 2-year residency of high-income countries, and this will put us more in line. I think, the short answer is we don't know. Will this deter people from choosing family medicine, or is it the case, and certainly some of the data seem to suggest this, that people are not choosing, our graduates are not choosing comprehensive care because they are feeling unprepared, and that in fact, more in-depth training and more support for training in comprehensive care family medicine will increase the number of people choosing family medicine, as that choosing continuity-based, relationship-based, office-based family medicine as a discipline. And so that's what the college believes, and they've got evidence to support it. And of course, we all worry that it could go either way, but I think it's going to be to us as educators to try to figure out how to make it work, given that this is the direction that we're heading in. And part of what we're going to need to do is to fix the system so that it's a system that our graduates want to come out and work in as family physicians.
Yeah, fully agree. And I think, that data that you showed, I think really highlights that point as well, given that amazing value that family physicians bring to the system. I guess actually another question I'd have very briefly for you is in terms of accessing some of that data and literature. I'm sure many of us kind of in our respective jurisdictions often have to kind of communicate around and kind of push back against some of these narratives. So are these accessible somewhere that we can easily access them?
Yeah, so the briefs are easily accessible, and I'd be happy to provide a deck that's got some key messages as well that could be posted on the Community of Practice site for those who are interested.
Wonderful. So with that, I'm going to bring the session to a close, and I just wanted to give a few reminders to those who are attending today. So our next session is going to be on January 20th, and I wanted to highlight that that one is going to be specifically dedicated to therapeutics, including Paxlovid. So I know that there were a lot of questions about Paxlovid, and we'll certainly take a lot of those questions back that we couldn't get to today. But rest assured, we're going to have a dedicated session related to that. I also wanted to just highlight a few resources that were mentioned in the chat earlier around virtual care. Ontario MD, I note that their Chief Medical Officer, Chandy, is on the call today. And they've mentioned that for anyone who needs support with implementing virtual care in their offices, Ontario MD does provide that service. So reach out to them and feel free to get connected to help get that support. And then also there were some other resources shared around counseling resources for Paxlovid and other types of documents. So please feel free to take a look through and check out those links. And with that, I want to wish everyone a safe, happy holiday season. I hope you get some time to recharge, and we look forward to seeing you in the new year. Tara, did you have anything you wanted to add?
No, maybe Olivia, do you want to put up the last couple of slides, and we'll just go through to the end to let people know about a couple of upcoming things. Maybe we can put up exactly, this is perfect. Just wanted to let people know that the Family Medicine Summit is happening in January, and registration is open, and there's a wonderful panel of speakers, lineup of speakers for the session. Next slide. And reminding people that we continue, of course, as family doctors, to see a lot of mental health and addictions in our practices, and the Practicing Well community is also a wonderful resource for folks. If you love our community of practice, check out this other community of practice as well, also co-organized by the Department of Family and Community Medicine at U of T and OCFP. Next slide. And then our last slide here is just a reminder that our next session is on January 20th. And as Ali said, we're hoping to focus on Paxlovid in the context actually of a large national randomized control trial that will be launched in January to help to answer some of the really fantastic questions that have been put in today's session around the effectiveness of Paxlovid and which groups may benefit. So really the only way to answer those questions is through good research, and a lot of that research needs to be done in primary care actually, because that's where we're seeing so many of the patients in prescribing these drugs. So thanks to everybody. Thanks to Ali Damji for taking on the co-moderation role and moderating today's session. And thanks to the panelists and all of you who continue to do incredible work. I just wanted to add my thanks. It's been an incredible 2.75 years, and it's been pretty evident in these sessions interacting with hundreds of you every 2 weeks how dedicated you are to the work that you do. And we thank you for it. It's not gone unnoticed, and we're going to continue to advocate and put forward a narrative that's positive about the work that we do. Thank you, and have a great weekend.